Hi, everyone, and welcome. I'm Jen Elder. I'm the director of the Homeless and Housing Resource Center. We are excited to welcome you to the office hours, following up on our webinar on funding supportive housing services for people with behavioral health needs. So we're excited for this session to help get your questions answered following the webinar and all of those questions that you submitted to us in advance. But to begin, as we begin with all of our webinars, just a quick disclaimer: we are funded by the Substance Abuse and Mental Health Services Administration, but the views and opinions expressed today don't necessarily represent those of SAMHSA or HHS. So go to the next slide for some quick housekeeping. Perfect. One more. So we do have our American Sign Language interpretation with us today. If you have any technical difficulties, just reach out, let us know, and we will troubleshoot that with you. And then going forward, one more slide, quick housekeeping. We so appreciate those of you who submitted questions in advance of today's office hours. The presenters have worked hard on gathering some answers and resources for you. We've got some great links, but keep those questions coming to us today through the Q&A feature, and the panelists will get to as many as we're able to in this hour. We do have these very short slide deck available on the website now, and we'll have a recording of this in about a week. So as with the webinar, we'll have a short evaluation at the end if you'd like a certificate of participation for joining us today. So with that, we'll introduce our panelists. It'll be Rachel and Sherry from the Technical Assistance Collaborative. Glad they can join us again. And I'm going to hand it over to Rachel to get us started with the office hours today.
Great. Thank you so much, Jen. Yeah, we got a lot of really great questions here, and it's great because it helps us to kind of orient ourselves to, how to help communities access resources that are available with more information and more details. So today we thought that we would go through, as Jen mentioned, the list of questions, and Sherry and I have divided those up and will respond that were submitted when folks registered. And if there's time for more questions at the end of that, we're certainly happy to take more. I think that if you have questions that you did not submit, it may be good to just put them in the chat, because that will help the Homeless and Housing Resource Center think about additional needs where communities can be supported in implementing these practices. So with that, I will start with the first two questions that were submitted. So the first question is, are there funds that can be allocated by developing more housing for the unhoused population, and what are barriers? So I'd like to draw your attention to the, I'm going to copy this link. I'm going to attempt to copy this link and put it into the chat. One of the issue briefs that we authored on behalf of the Homeless and Housing Resource Center, and now I'm having a hard time copying this from this page. So I might need some help, Jen. I'm sorry, or other partner. So the very first, let's see, no, it's the applying new COVID-19 funding to address the housing needs of individuals with serious mental illness. Okay, and all of the links Rachel compiled can be found here. So if you all open this link up, so I will let you know where you can find information, and that would be the second bullet down under the HHRC resources. So this is a document that we put together that identifies all the various resources that can be used, including funding for development, new housing development. And rather than take a lot of time to talk through that in this very short 1 hour, we would like to refer you to that resource, as well as then there is information about, under the HUD programs, the CDBG Recovery Housing Program, COC program, and ESG programs. which you may also want to take a look at with regards to how to fund new housing development. It will talk about HUD home grants. It will talk about low-income housing tax credits, and that information should be able to support you all. The next question we had is, are there grants for agencies that have supportive housing programs to fund SOAR services? And so SOAR services are those services that assist individuals in qualifying and becoming eligible and granted SSI and SSDI. And there are a lot of resources. If you open, again, the page with all of the hyperlinks under the SAMHSA program and resources, you'll find the SAMHSA SOAR Technical Assistance Center. So there's a lot of information there about SOAR models and how to build a SOAR program. But in addition, you know, there isn't a lot of funding that can be directly used to fund SOAR projects. In the past, the Social Security Administration did fund some SOAR pilots around the country, but funding for SOAR can come from a variety of partners in the community, including managed care organizations or hospitals. All of those systems really benefit from having individuals who are uninsured to qualify for SSI and for Medicaid, specifically in states where Medicaid expansion hasn't occurred, because it helps them to be able to bill for services of uninsured folks. So those are a couple of recommendations related to how to think about funding for SOAR services. Sherry, was there anything else on either of those two before I pitch you your first question?
No, I think you've answered them well.
Great. All right. So Sherry, for you, this first question is, can Medicaid pay for group homes or Section 811 housing?
So Medicaid has, you know, a couple prohibitions that are pretty significant. And one of those prohibitions is that Medicaid cannot, under normal rules, be used to pay for housing or room and board. There are very few exceptions for programs or facilities that are considered interim care facilities for people with developmental disabilities, nursing homes, those type of quote institutional settings, room and board is covered. But in a traditional housing or community-based living program, room and board is typically not covered, no.
Great, thank you. And your next question is, can supportive housing have service participation requirements?
You know, this is really an interesting question that we are seeing trends, I would say more so these days, where we're seeing programs want to require people to participate in services. The evidence-based practice of permanent supportive housing talks about the separation of services and housing. That is the model. But we often hear people say PSH doesn't work for our population or the people we serve because they have high service needs. What I say to people is, if you are serving, and PSH is intended to serve people who are challenging to engage and to house, you should expect that individuals will have service needs. The trick is, how do you engage them in such a way that they will want to participate in at least some types of services and supports, and maybe not the whole package from what, you know, providers may think they need, but it's really about engaging individuals. And we talked about, I think, you know, people with lived experience being part of that engagement process. You know, individuals are more likely to trust someone who's walked their walk, and those peers can help a person to understand that by participating in a certain service or taking meds or doing certain things, they benefited and actually ended up moving forward on their path to recovery. So the model is really intended to not require people to participate in a very set, a number of services or type of services. But the best practice really involves engaging and re-engaging and engaging again and not giving up on helping people understand the benefit of services for their ongoing housing stability and pathway to recovery.
Great, thank you, Sherry. The next question is, do you believe it would be most productive to have peer support specialists during intake process or once participants are enrolled?
Both. I have to say, I am a very, very strong advocate of peer support, recovery support, people with lived experience being part of the process. And the sooner they make a connection and engage with someone that you all are wanting to serve in housing, the stronger that relationship is likely to be, the better it will be established, and the more positive impact that relationship will have on the individual's attainment and being stably housed in their housing ongoing. So I don't think you can have peers involved too soon, and I certainly would recommend and have observed that their ongoing support is just critical to helping people remain stably housed.
Thank you, Sherry. All right, the next question is, do you have any alternative housing suggestions for younger individuals with severe mental illness that also require physical assistance?
So I guess I'm a little unsure exactly what the question is trying to get at. There are certainly youth homeless programs and projects and models that my colleagues at TAC work with communities to establish all throughout the country. I understand there certainly are differences with young adults versus, older adults, but living, in an independent setting with services and supports is essential, no matter what the age is. It could be an older adult, it could be a young adult, but certainly engaging those young adults in, things that other young adults want to be involved in, positive social activities, educational opportunities, job training, things that will help them to learn independent living skills that they may not have obtained to this point, and then being able to, have skills that will help them to have income, to, be independent. Those are all really important things, and to learn healthy, positive social engagement. I would say youth peers, young adult peers, again, are very, very helpful with those approaches. Now, when you have individuals that also have physical health needs or physical disabilities, you need, pretty strong care coordination. And there could be some additional in-home services and supports that would help those young adults to, again, be, more independent. The use of technology is extremely important for people with physical disabilities, and particularly a young adult who is probably very savvy in the use of technology versus some of we older folks. I think there are a lot of opportunities to use technologically supported equipment and apps and innovations within a housing setting that can help young adults to be very independent and, again, move on their pathway towards adulthood.
Great, thank you, Sherry. And additionally, I put into the chat the link to the HUD Youth Homeless Demonstration Program. There's a lot of information, training materials there for working with transition age youth who are exiting from homelessness into housing. And then also wanted to include in here a SAMHSA resource related to early serious mental illness treatment. And this is actually a locator so that folks can look to see in their state or their locale if there are any early psychosis treatment programs. And you can learn more about the best practice at that link. All right, so moving on to the next question. this person is interested in whether there may be new funding coming out for recuperative care, medical respite programs for homeless individuals. And I do have a link here that I'm going to share, but medical respite programming, I believe that Medicaid may now be looking into this question, and medical respite is often used as a lower level of care in which folks are discharged from hospital, inpatient hospital stays into a lower level of care, usually where a person may be, there's access to nurses or EMTs who can help support the care and make sure folks are taking their meds to continue healing, but in a less costly environment, as well as assisting people in being connected to a primary care home and in accessing housing once they're discharged from medical respite care. So here is a report that came from, I believe it was the National Healthcare for Homeless on medical respite care. I want to say that in addition to looking at whether there are opportunities to fund this through Medicaid or through managed care organizations, that again, hospital systems have worked in partnership with communities to look at some of their more costly homeless patients and to enter into contracts with housing providers to set aside a group of units to operate recuperative care programming. So that's a potential source of funding to consider.
I would just add that, and you mentioned managed care, a number of managed care companies that I'm familiar with will and have funded this type of service and support because, as Rachel said, it does serve as a transitional opportunity for people to leave an inpatient setting, but to not move into independent living or on the streets where, you know, they won't necessarily be able to receive the type of rest and support and medical oversight that they would benefit from. So if you are serving people that are enrolled in managed care, I would, strongly encourage you to follow up with those plans and to learn whether they cover this type of a benefit.
Great, thank you, Sherry. And the next question relates to recovery housing. And this question asks, how can accredited recovery housing providers become qualified to receive housing funds and or HUD or Medicaid clients? So I included in the chat 2 links. The first one is to the National Alliance of Recovery Residences, which is a national organization that is working with states to adopt standards of practice for recovery housing. And many states have, it's called NAR for short, have NAR affiliates. So that link you can look up to see if your state has a NAR affiliate and reach out to the NAR affiliate about available resources in your state for funding recovery housing. And then the second link is to the HUD Exchange Community Development Block Grant Recovery Housing Program. And so the last couple of years, not a lot of money, but some was allocated for recovery housing, and it's being administered through state housing finance agencies. So there are about 27 states that received funding to pay for recovery housing development or operation. And that website, you should be able to find, again, if your state is one of those states that received that grant funding, you can reach out to your state housing finance agency or to your behavioral health single state agency. So the body that's responsible for overseeing the SAMHSA CSAT block grant. So the Center for Substance Abuse Treatment block grant. So those are 2 really great resources. Okay. And the next question is for you, Sherry, and this one is, how can tenancy supports be supported through Medicaid?
We talked about this last week, so to review and refresh, there are a couple different options, and it does vary across states, and it varies across target populations. For individuals with, say, a developmental disability, or who would potentially meet criteria for a nursing home level of care, states can apply for waivers to cover a broad array of services that will support people in more independent type living, supportive living type arrangements. So states, many, will and do have waiver coverage for tenancy supports for individuals with, certain diagnoses or conditions. For individuals with serious mental illness and substance use disorders, they are oftentimes, they don't meet that criteria to be in a Medicaid covered institutional setting. So waivers typically aren't available for them. However, states have some new authorities we talked about, and I know this is all very technical, I'm sorry about that. Demonstration waivers, these are new types of waivers that are available that many states, and Washington State was one that we used as an example, have received approval from the federal government to pay for pre-tenancy as well as tenancy sustaining services for people with both mental health and substance use disorders who one of the additional criteria may be homeless or in need of housing stability. So states are able to get federal approval to fund the package of supportive housing services. However, not all states have gone down that path. They may not have been able to get support to do that. So states are able to cover tenancy supports through some existing Medicaid covered services that they have, such as we talked about peer support. Many states have Medicaid coverage for peer support services, and peers can provide a number of activities that fall under the definition of tenancy supports. Many states have Medicaid coverage for something called psychiatric rehabilitation. And some of those states include in-home, what they call mobile or in-home psychiatric rehabilitation. Those services can go into an individual's apartment and help them to learn or relearn how to take care of their apartment, how to prepare menus, how to cook again, budget their funds so that they can pay their rent, a lot of the living skills people need. Assertive community treatment teams are Medicaid covered in many states. Many of those teams have housing specialists, and they can help to provide a whole array of pre-tenancy and tenancy sustaining services. Targeted case managers can help to monitor and go on site to a person's independent living unit and check in and see how they're doing and link them to other services or resources they may need that would help for them to have a more successful living arrangement. So there are different possibilities. It's learning and understanding what's available in your state based on the population that you're serving.
Thank you, Sherry. And I also included in here a link to a HUD and HHS sponsored webinar on Medicaid resources for housing support services that we put together last summer. And it may be another resource. So we did refer to in the guide that we just published a lot of the information in that webinar. So, great. All right. I did want to also, I know we're just sending you guys so much information here. I remembered that back to the recuperative care question, that California's Medicaid waiver did allow for recuperative care. And I just put the link in here to Oh, it doesn't look, it looks like I just repeated what the, so I will go back and get the, here we go. And it's on page 10. So I'm going to try this again, where you will see information about how California built into their Medicaid plan coverage of recuperative care. So our next question, Sherry, I think this is how we all felt when we came into this field, is I am overwhelmed with just entering the field and learning about all of it. What can you say to me?
It is overwhelming. I have been working in the system for 30 plus, and I do mean plus years. And all of those years have involved touching Medicaid in some way or some form. And it is very complicated, and it becomes, for good reasons, it seems more complicated as time goes on, because the federal government has been responsive and making additional opportunities available to states to be able to provide coverage for services and populations. And that's a good thing, but it certainly does add complexity to the program. We have added, and there are links, and Rachel, I'm going to have to rely on you for that. In the document with links and resources, we've provided a couple different options for folks to take a look at. They are all, how do I want to say this? They're general in the sense that they don't apply to any one state. They apply to an overview of Medicaid. What it is, what some of the options are, what the mandated services are, target populations. But given that, I will say that how it plays out in your individual states will be different. And in some cases, it will be very different. A state like, California, Massachusetts, New York, many states, have taken a lot of advantage of some of these newer opportunities to create very wide nets of services and supports. Not all states have that opportunity or have had the fortune and support to be able to do that. So how Medicaid looks in your state could be very different than how it looks in the state right next to you. That's part of what makes it complicated. But, there are partners that can help. Again, we've provided some resources that are, in a bit more what we call plain language, making a connection to someone in your state who understands Medicaid. I can't recommend that enough. You need partners to do this and to do it well. Whether it's a managed care company, and, they have lots of information and provide lots of technical assistance to providers. The Medicaid program itself may also do that directly. They certainly do provide a lot of online resources, but again, having been someone who's combed through those resources, I know how challenging it can be. Sometimes organizations like the National Alliance for Mentally Ill, state advocacy organizations will also help to create resources that help individuals and families and other stakeholders in the system to understand about what benefits are available and how to access them. Develop partners, make connections with partners, your local behavioral health authorities. They also will have some level of understanding, probably some more than others. Or they can at least help to connect you to a point of contact for Medicaid if they don't have one themselves. Make those connections. It's really the most productive, I would say, way to get a good understanding or a better understanding of what benefits are available to the people you serve and support.
Great, thank you, Sherry. So here's a request in plain language to describe who's eligible, how long the benefits last, and what is the income limits.
Again, the very first resource under the Medicaid, I believe it says it's from the CMS is in the tagline. I would send you all to that as the first link to open up and tap into. It's pretty plain language. but it is from a federal perspective, so it's not going to give you all of the intricacies of your state. States have had options through Medicaid expansion. I'm sure you all have heard about that, to be able to expand eligibility to single adults that don't have dependent children, typically between the ages of 20, I believe it's 22 and 64, with income limits at a higher amount beyond the federal poverty level than traditional Medicaid. So if your state applied for expansion, people are eligible with higher incomes, not, high incomes, but higher than for states that don't have Medicaid expansion. And some states have even, extended beyond that. So it's really understanding the eligibility for your state that is most important.
All right. Here's another one. The most important thing to consider when implementing Medicaid billing into supportive housing services is, and can we expect program changes when we do this?
So another trend I think we've seen is that, and I'll use the term states because I think it starts at the state level. States, as they have had their block grant funds or discretionary funds in past years reduced, states relied more and more on Medicaid to cover services. And some of those services could be the very services you're talking about or you're referring to. When that happened, Medicaid rules kicked in, and it's true. When you bill Medicaid, there are pretty specific rules you have to follow. You have to be an eligible provider. The staff have to meet eligibility requirements. And these are all laid out in service guidance within your state. And they vary from service to service. The person receiving the service has to meet eligibility criteria. There are lots of rules you have to follow. One of the things I think that get people most in trouble with Medicaid is documentation. Service documentation is the key to billing. And you have to follow your state's Medicaid requirements for documentation of the service. Documentation has to meet the definition of the service. If you are providing a service that says you can receive Medicaid to take John shopping, then your documentation has to reflect that the service you provided was taking John shopping. If your service you're documenting is you and John went to a ball game, that's going to be a problem because that's not what Medicaid is paying for you to do. So documenting the service according to your state's rules or managed care company's rules is very important. But getting back to the original point, you may do other things. It may be really important for John to go to a ball game, and that may help to keep John on a solid path, and it might be something he really enjoys. You've got to be able to have other funding sources braided with that Medicaid to provide that full array of services and supports that will help him to be successful. So program changes, I really would encourage people not to think about program changes so much as how do you grade and find all the funding sources that can be brought to bear to provide the program in the way that is most successful and beneficial to the people you serve and support. Medicaid can help with that, but it may not be the only solution.
Thank you, Sherry. All right. Let's see here. Is there anything more you wanted to say about what needs to be in place before you can receive funding? A provider organization can bill for Medicaid?
Well, you have to be an enrolled provider. If a person is Medicaid eligible and you're providing a Medicaid service, but you're not enrolled in either your state's Medicaid program or your managed care provider network, they're not going to pay you. So you've got to enroll. Now, there are lots of rules and processes to go through to enroll. But again, there also tends to be, assistance and guidance to help providers through that process. And once you do enroll, as long as you continue to follow the rules, you stay enrolled. They don't turn around and disenroll people unless they really violate egregious, Medicaid rules. So you get through that process, you're usually pretty good to go for being able to serve and support people ongoing. And someone asked a question, one of the earlier questions was around, is Medicaid coverage time limited? Once a person is Medicaid eligible, they tend to go through, states require them to go through like an annual review process. And basically what that involves is, just showing that they continue to meet the criteria, whether it's income, whether it's disability, whatever it is, that they remain eligible. And as long as they remain eligible, coverage continues. So it's not typically a time-limited benefit to be eligible. Now, services may be time-limited. In some cases, that's true. That's another complication. You have to know and verify if a service is time-limited. For some benefits, it's as long as it's medically necessary. As long as the person needs the service and continues to need the service, the coverage continues.
Great, thank you, Sherry. So this next question, what resources are available for individuals without housing or income? So here I would like to, I'm not going to copy and paste it into the chat, but if you look at the document with all of the links, you'll see under HUD that there's the HUD COC, so the continuum of care by state, and that link will take you to, you can look up your state and your jurisdiction if you're not already in conversations or a part of your HUD continuum of care. Also the emergency solutions grant information by state and locale. And so, there are resources to assist folks who don't have any income to qualify for rental subsidy or rental assistance. A lot of that comes from HUD, but also different states have opted through general funds or even county general funds to obligate funding for rental assistance. The good news right now is I think there still is a lot of money that is flowing into states related to the American Rescue Plan, a lot of emergency housing vouchers that housing authorities were given to obligate for individuals who are experiencing homelessness through the coordinated entry system. And so I think it's a matter of identifying who the agencies are that operate those rental subsidies or rental assistance, and then of course finding available housing that will accept those. I think right now a lot of communities are really struggling with. The next question, Sherry, is with Medicaid funded supportive housing, will there ever be physical disabilities made eligible for assistance?
Again, given the wording of the question, I'm a little unsure what you're asking, but I'm going to give you my best thinking on this. Medicaid actually started covering services and supports in more independent living for people with physical disabilities well prior to individuals that had behavioral health disorders because of that nursing facility level of care. But that's the caveat. Many of those individuals have to meet nursing facility level of care. And if they do, the waiver in your state is likely to cover services and supports in an independent living setting, like an apartment or their home. Where I think people tend to fall through the cracks, I'll use that term, is that they don't meet nursing facility level of care. They may have a disability and your state plan doesn't cover in-home services and supports for individuals that don't have that highest level of need. I'm assuming what you're, or at least what I'm interpreting in the question that you're submitting. So you're able to provide permanent supportive housing for people who have serious mental illness, they have a substance use disorder, but if you have an individual who doesn't have either of those disorders, but who perhaps is in a wheelchair or perhaps has, some pretty significant healthcare health conditions, they may not be covered through supportive housing benefits in your state. And it could be that is true. I would, again, if they have another condition, to try to serve them and support them, covering them under that other condition. But I suspect that's what you're asking, and some people may not be covered unless you, again, reach out to those partners to make sure you're not missing something so that they can get the services and supports that they need as well.
All right. Thank you, Sherry. The next question asks about what are community resources for homeless population and programs for low-income families? And I neglected to include this link in the beautifully formatted HHRC list of web links, but I'm sure that can be revised. So this link goes to the Administration on Children and Family webinar that was co-sponsored by HUD and Health and Human Services last summer. And it does a beautiful job of outlining all the various resources within the Administration on Children and Family that can be used to cover supportive housing services. And so that's a great place to start. I would also just urge you again to work with your HUD continuum of care, as well as area community action agencies, which have a lot of, receive a lot of federal and state funding related to families and children to support in reducing poverty and supporting the housing needs of families and children. Sherry, was there anything more you wanted to add to that one though?
No, I think you got it.
Okay, great. The next question is, what information is needed to obtain supportive housing? So I'm going to interpret this question as if an individual would qualify for supportive housing or not. And so typically, again, your HUD continuum of care will have what's called a coordinated entry process in which they are interviewing individuals to determine the various needs that they have that can be met through supportive housing. So that would typically look at one's income, the length of time a person has been homeless or in shelter, the number and age of all family members, any benefits and entitlements that the family receives, any history of domestic violence, those kinds of things. Or for individuals also, if they have any federally recognized disabling conditions. So those are the types of information that the coordinated entry system will assess for to determine if a person qualifies for supportive housing. And I think that is all I have on that one. So the next question is, I'm trying to figure out how to get funded for a peer run or sober recovery housing. Where do I begin in Michigan? So again, I'd like to refer you back to those two links, the one that is specific to the NAR, the National Alliance of Recovery Residences, which should be able to show you a map of the United States, and you can look to see if in Michigan there is a NAR affiliate. And I would recommend reaching out to the affiliate for more information. And then I think also, using the links for the Peer Recovery Center of Excellence, which is housed out of SAMHSA, and I'm going to include that link in the chat right now, would be another excellent way to look at what's available out there and as well as some case studies of individuals who have started peer-run recovery housing, to be able to get a sense of what might be involved and where some first steps might be. All right, and the next question is, are there any specific housing funding sources for transition-aged youth? So I believe earlier I did include information related to the HUD YDHP program. So there are housing funding sources for transition-aged youth funded through HUD. And I would encourage you to go to that link to learn more about that, and to perhaps also discover if there are any YDHP grants in your locale, so that if you have youth who you think would benefit from that, you might be able to discover what the referral process is. So that is the list, the end of the list of questions that we received during the registration. I think there are a few questions in the Q&A, and I'm going to start looking at those, and we can see if any of these we'd like to try and answer here on the spot.
Rachel, while you do that, I would
Yeah.
also like to reflect back on some discussion we had during last week's session. A number of you had asked some questions about supporting individuals who are incarcerated, and how do you do that, you know, with Medicaid. I wanted to clarify some information that I shared last week. What I would like to say is I used the term eligibility, and that was incorrect. That truly Medicaid eligibility is not prohibited or precluded due to incarceration. However, coverage for services is what is impacted when someone is incarcerated. There is something called an inmate exclusion, which is a federal rule that prohibits Medicaid from covering services or inmates care, except, and there is one except, if they are transferred from the correctional facility to an inpatient setting. So if someone is incarcerated and has appendicitis or has an emergency psychiatric issue that needs inpatient care that they are not able to provide in the correctional setting, the person can have that service, that inpatient service, covered by Medicaid until they're able to be released and then are returned back to the correctional facility. But the eligibility itself does not end according to the federal government. What states do tend to do, and I did say this last week, is they tend to suspend eligibility when someone is incarcerated for a length of time, and then that eligibility is reactivated when the person is re-entering back into their community, so they don't go through that long process of reapplying. But I did want to clarify the difference between eligibility versus actual coverage for services.
Thank you, Sherry. And I did include in the links a Medicaid state resource related to justice involved for folks to look at that further, as well as information about the SAMHSA Gain Center, which offers technical assistance to behavioral health systems related to designing reentry programming, including housing. Thank you. Yeah. I have a couple of questions here from Tanya. So Tanya's asking if Medicaid will pay for addiction services that are integrated with housing. And she also asks about if HUD is providing any funding for housing supports that are harm reduction oriented. I think there's a little bit of a typo, Tanya. So the answer is that, you know, Medicaid in many states does cover addiction services. And we've talked about how housing related supports or supportive housing can be covered through different Medicaid plans. And so, you know, I believe that individuals can be enrolled in addiction services and be covered for those services through Medicaid, while also receiving housing related supports through Medicaid. Sherry, would that be your interpretation?
I guess if I'm hearing you ask though, can say a recovery house or an Oxford house bill for some of the therapeutic support that someone is receiving on site? I don't know that that would be a sanctioned opportunity. You know, there are individual counselors or, you know, recovery specialists that are able to provide their services in certain settings. And obviously you'd want to know where they are. But if you're looking at a creative way of billing for services in a program, that sounds like a bit of a one-off way to go about doing it. And I would be very cautious about trying that approach. And maybe I'm misunderstanding what you're asking, but that's what I heard when I heard the question. And
you cannot offer like outpatient treatment on site in recovery housing, because that would be interpreted as an institution of mental disease. And there are lots of rules related to Medicaid that will not cover that. But a person could be receiving outpatient treatment, living in recovery housing. Right. Those two service providers can't integrate care. So, and then the harm reduction question, yes, absolutely. I mean, HUD through the SNAPS program, which consists of the continuum of care and emergency solutions grants, like harm reduction is very widely referred to as an important best practice in serving individuals who are exiting homelessness and using housing first. So let's see, the next question we have is, this approach was thinking about certified, oops, sorry, cancel that. Is HUD providing, okay, that was the question we just answered. And then how long will the suspension last? I'm not sure of that question, what that is.
If you're referring to the Medicaid, it's for as long as the person is incarcerated, is my understanding. So if they're incarcerated for a year, their benefit could be suspended for a year and then reinstated when they re-enter the community. If it's for 6 months, it would be for 6 months.
Yeah. Okay. And then we have, I'm sorry, Tanya, I don't understand. Well, harm reduction clients are in need of services. Yes, they are. And services can be offered using a harm reduction approach. So I apologize. I'm not quite sure I understand the question. There's a question at the top here. Any thoughts on HUD Home ARP funding, which provides funding for affordable rental housing, TBRA, supportive services, purchase and development of non-congregate shelter for what HUD defines as qualifying populations? I am a little bit confused by that question. And Sherry, I kind of want to refer this person to that first brief that we published related to how affordable housing, sources of funding for affordable housing. And then the second brief related to the supportive services.
There has been a lot of federal funding that's been made available over the past few years to really support both the development of new housing, the rental assistance, which was identified through additional housing vouchers, emergency housing vouchers. There was another one. Rehabilitation of housing units to bring them up to codes and standards so that people don't lose the housing that they have. Making connections again at your local level, because a lot of that fund was distributed at the community level. States further distributed it to local communities, would be, helpful in understanding what's still available in your local communities, as well as how you can partner with other entities to go about accessing those resources, those dollars to, provide additional housing support to individuals in need.
Great. And then she writes again, just home ARP. This is new funding. Again, I would refer you to the first issue brief that is, and if I go to the document with all the hyperlinks in it, that would be the second bullet under the HHRC resources applying new COVID funding, because I know that there is a home ARP section in that. Both Sherry and I have more expertise on the services side. We have wonderful colleagues who could answer this question very adeptly. We're just not them. But they did contribute to that first guide. And John says, I'm wanting to know about funding for clients with a history of arrests and mental illness and substance abuse for housing. There seems to be so many constraints to support under these circumstances. And yes, John, I would agree with you. There are lots of constraints. I worked for two large FQHC affordable housing operators that owned very large portfolios of low-income housing, and we were able to really work very effectively to house folks who had histories of incarceration with mental illness and substance abuse. I might direct you back to the HHRC 4-hour training curriculum to learn more about that there. And with that, Jen, I think I'm going to turn it over to you, because it looks like we're close to the end of our time, and I know we want people to complete this exit survey.
Great, thank you so much. I will just start by saying I am so in awe of your expertise on funding services and Medicaid. I know this has been incredibly beneficial to the community, and this has just been a great opportunity for people to submit their questions and the amount that you could cover. We just so appreciate your time with that. And so for our audience today, we've got just a very short evaluation that will link you to a certificate of participation. I'm also, as a reminder, going to put in the web page that will have the recording of this. It has the evaluation link, the link to the handout with all of those wonderful links that Rachel was covering, and we will add that extra one as well. But yeah, thank you so much, team, and we look forward to everyone joining us at future events. And email us if you have ideas for topics you'd like us to cover. We would love to hear from you. All right, thanks so much. Have a great day.